All right, so my name is Katrina. I am with the Michigan Opioid Collaborative. And today we have Dr. Morrow presenting for us. The Michigan Opioid Collaborative has committed to doing a monthly webinar series, so I hope you'll join us for more webinars in the future. Everyone will be muted during the presentation. If you have any questions, you can put them in the chat and we will get to them at the end. Also, if everyone could sign into the chat box with their name and email, just so we can give you attendance for or credit for attending today. Also, if you would like to receive information on future webinars, please let us know in the chat also. I will also be putting a survey link for social work CEUs in the chat box. So please fill that out as soon as possible. And at the end of the survey, it will redirect you to the certificate. So I'm going to go ahead and introduce our speaker. So we have Dr. Morrow with us today. Dr. Jonathan Morrow received his MD and PhD in neuroscience from the University of Michigan. He is currently an associate professor of psychiatry and also provides clinical care to patients through the University of Michigan Addiction Treatment Services. Dr. Morrow is also the principal investigator of a basic research lab that studies individual variation in the neurobiology of motivated behaviors. So welcome, Jonathan Morrow, and I will turn it over to you.
Okay, thanks. And thanks for everyone who's in attendance here. Let me share the presentation with you. Okay, so you should be able to see it now. Yeah, you should be able to see it. Okay. So I'm gonna, this talk is gonna be about psychostimulants. I'm gonna focus on cocaine, amphetamine, and methamphetamine. If we have some time at the end, I may mention some other ones, but it's definitely gonna focus on those particular stimulants. And there we go. So I don't have a lot of disclosures, but I put my grant funding on here. I may talk at least briefly about some off-label uses, but I won't spend a lot of time on that aspect. Here are some of the things that we'll try to cover. I'll go over pharmacology of these major classes of stimulants, talk some about the psychiatric and medical consequences of stimulant use. We'll talk about treatments for stimulant use disorder. And I'll also talk a little bit about the historical context and societal impacts of stimulant abuse. So with that, I'll just talk about, I like to have this kind of fun slide about some of the street names that people use for these drugs. There's a million of them. I can't keep up with them all. Some of them are pretty creative. I think my favorite is Methley's Quick. I thought that was pretty clever. But there's a lot of different names that people have for these. And I'll just point out that this is a timely topic because there's a lot of focus, and rightly so, on opioid use and opioid dependence, in part because of the overdoses that people get with that. And I think we just topped 100,000 overdoses in a year for the first time with opioids. But that focus actually kind of masks other increases in substance use that have been going on at the same time. Alcohol use has been going up, cannabis use has been going up, benzodiazepine use, which nobody talks about. And stimulant use has been going up at the same time as well, particularly methamphetamine use, and also cocaine use, to the point where now cocaine and methamphetamine overdoses, there's more of those than even heroin overdoses at this point. So they're big problems, and they're just actually getting bigger at the same time as we're trying to deal with this opioid crisis. Um, we'll first talk about cocaine, which comes from the coca plant. It's a kind of boring looking shrub that is native to the Andes region of South America. So like Peru and Bolivia is where it grows the best. So that plant produces cocaine and other alkaloids, really as a way of discouraging browsing from herbivores. And it's been used for thousands of years by indigenous people in that region. And they use it for various purposes. There's religious rituals, to be sure. They used it medically as a local anesthetic. They did use it for pleasure as well, just recreationally. And it was used as a performance enhancer, because this is in the Andes region. It's very high elevation. It's a mountainous region, and so the oxygen content is low. So it's really hard work doing things at elevation, if you've ever tried that. So having a stimulant on board would give people more stamina. And in fact, when that region was conquered by the Spanish, they outlawed cocaine use because it was used in these heathen rituals. But then when they discovered that people worked harder when they were on cocaine, they actually forced the enslaved indigenous people to use cocaine when they were working them to death. So it's used for similar purposes now in modern society. So this is the kind of chemical name. I won't even try to say the actual chemical name of cocaine, and I put the chemical structure up here. This is it's an alkaloid compound, as I said, produced by this coca plant that's similar to other alkaloids. One example would be atropine, which plants have evolved to discourage predation, so from browsing from deer and things like that. So a lot of these compounds are deadly, and that's what gives the plants a bitter taste. That, in fact, that's probably why it's the sensation to us is bitter, is because these alkaloids, so many of them are deadly like that. So that's the purpose of it, and some of it has a number of pharmacological actions. So one of the main things that cocaine does is it blocks voltage-gated sodium channels. So what that's going to do is block neurotransmission, all neurotransmission in the area. So, and cocaine is very good at that. So it's an excellent regional anesthetic. That's one of the reasons that hospitals still have it on formulary. It's probably the best local anesthetic that we have. And that's, and when you see in the cop movies, when they take some powder and they taste it and they say, oh, that's cocaine. So that's what they're sensing, is it numbs the tongue, along with that bitter taste would tell you that it's cocaine. It doesn't really taste like anything particular. Another thing it does is it blocks norepinephrine reuptake, which causes vasoconstriction. So it's also an excellent vasoconstrictor. Another reason that hospital has it on pharmacy is because if you have a bloody nose, cocaine is the best way to dry that up, really. But the reason it's addictive is because it blocks other monoamines, uptake of other monoamines, so serotonin and dopamine, along with the norepinephrine. And because it blocks dopamine reuptake, particularly in the nucleus accumbens, anything that increases dopamine in the synapse here, in the accumbens, is going to have that will have addictive potential. So a little bit of history of the modern history of cocaine. So the active ingredient in coca leaves was isolated in Germany in the mid 1800s. This was kind of the golden age of organic chemistry, particularly in Germany. And it was marketed widely in several different products, including Vin Mariani. They just added cocaine to wine, and that was extremely popular all over the world. The inventor actually got a medal from the Pope for for inventing this. It was used to treat morphine addiction. You see this a lot through history, where you use one addictive drug to treat another one. So the cocaine actually was not effective in that regard, but people tried it as a cure for morphine addiction. It was famously used in Coca-Cola, and that company, and there's a few other ones, they still use extracts from the coca leaf. They just don't use the cocaine part of it in the product anymore. So it was sold over the counter for for several years, and it was famously endorsed by Sigmund Freud. He was a big proponent of cocaine. And then use of cocaine declined in the 20s and 30s when it started being regulated. People were recognizing the many really addiction-related problems that came from cocaine use. And amphetamine was introduced around that time. So kind of the things that people would get out of cocaine, they had a replacement for that in amphetamine. There was a resurgence in popularity in the 1970s with powder cocaine, and then later in the 80s with crack cocaine. So a little bit about how cocaine is produced. So cocaine leaves are, it's produced from the leaves. So those leaves are harvested, usually in the Andes Mountains region, although a lot of the current production is dominated by Colombia, and Mexico has started to move into that market pretty heavily. It grows much better in Peru and Bolivia, but they're able to get away with it more in Colombia and Mexico. So they harvest the leaves, and then they add a solvent to, they grind up the leaves within a solvent to kind of concentrate the cocaine. And so that makes it's not that hard to do, really. And they will get it into a fairly concentrated cocaine paste. So a lot of times that can be done right in the field where the cocaine is growing. Although if you have a big production, you can send it off somewhere to have this step done. And then at that point, you add some type of acid. You can do several rounds of this, but at the end, it's usually hydrochloric acid that's used to make a water-soluble salt. And then you can bake that into bricks, and you get pretty pure cocaine at that point, which then you can export. Mainly in the 70s, people would freebase cocaine. So freebase is so the problem with cocaine hydrochloride, it's very compact and easy to move, but you can't smoke it. And so the most addictive way to use this, we'll get to use to the brain very quickly. More like on the order of a minute or so. if you're injecting it. But if you just try to smoke cocaine hydrochloride, it'll just burn. It's not stable that way, and then now you've just wasted your cocaine. So if you have a base on there instead of an acid, that stabilizes the molecule, and then it'll form a vapor which you can inhale. So you can do that by adding a base like ammonia, and then extracting it again with another solvent like ether. The problem with this method, though, is that the people doing this are not very precise, right? So if you don't completely eliminate the ether out of that final product, then when you try to light that on fire, it's going to explode because ether is very flammable. So the pipe will explode, and that's what happened to Richard Pryor. Catch your whole head on fire. In the 80s, it was actually in LA. There was a dealer called Freeway Rick who figured this out. You can, instead of using ammonia and ether, you can just add baking soda for your base. And so if you mix that up and just heat it up in water as your solvent, which is much safer as a solvent, then you can bake that out into crack cocaine, which is actually even more stable and can still be smoked. And it's very cheap. So that came to dominate the cocaine use because, again, crack gets to the brain much quicker, so it's more addictive in that form. So when you see cocaine, used on the street, so they say, that's not going to be pure cocaine. It's initial when they manufacture it and send it out. That's going to be pure cocaine. Is easier to transport that way. But when it's actually used, it's 100% of that is going to be cut with something. Usually the purity is around 40% or so cocaine. If you actually get pure cocaine to somebody who's been using it, that they're going to overdose because they're just not going to be used to that. So it's cut with different things, some of which can cause different types of medical issues. So some of these would be bulking agents like sugar or talc or cornstarch, which are relatively benign, except that when you inhale that stuff into your lungs, it just sits there in the alveoli. And so you lose some lung capacity just by the same thing with baby powder and things. It just sits there and you lose lung capacity over the time just because you have this foreign agent in there blocking oxygen exchange. They'll also use local anesthetics, which are kind of cheaper, like benzocaine. That gives you that numbing sensation. But they can also cause things like methemoglobinemia if used in large amounts. And then sometimes they'll just put straight toxins in there, which are bitter again, but quinine, strychnine. You put rat poison in the cocaine, which just seems mean, but it's cheap, and these are unscrupulous people a lot of times. So they'll so you can anticipate those types of problems sometimes in people who are using illicit drugs like that. Another thing to point out is that a lot of cocaine users will binge along with alcohol. So it's really the majority of people who use cocaine will use it along with alcohol. What that does in the body is the liver processes that into a different drug. It processes it into coca ethylene. So that compound it's longer lasting, it's more rewarding than just straight cocaine. But unfortunately, it's also more cardiotoxic. So you're more likely to get a cardiomyopathy developing over time if you're combining cocaine with alcohol. But that's just something to keep in mind when you see people with cocaine use disorder. um, they may actually have an addiction to coca ethylene and not know it. So I've mentioned the pharmacodynamics a couple of times already, but just to illustrate this, so how you use the drug is going to influence how fast it gets to the brain. And you can think of addiction as a learning disorder. It's kind of a subconscious process where the dopamine release that you're getting that makes you want to do the drug again, your brain has to connect that with an action. And if that action was right before the dopamine release, it's very easy for the brain to make that connection and promote that behavior again, which leads to addictive behaviors. If there's a long period of time in between those, say you chew a coca leaf, you digest it, and then a half hour, hour later, you get the effects in the brain, the dopamine release. You've done a whole lot of other things in between there, so it's harder subconsciously for the brain to connect that dopamine experience with the act of taking the drug. And so if you snort cocaine, that gets into the brain within 5 minutes. IV, it's more like a minute or so. But inhaling it, you bypass most of the circulatory system. It just goes, all it has to do is get through your lung to the heart and out, right out to the brain. That happens within seconds. And so when you get that dopamine release, the crack pipe is still in your mouth at that point. So the connection is very easy to make, and you get much more intense kind of addictive behaviors with that. So crack really is more addictive than powder cocaine. I'm not saying that justifies any of the sentencing differences that you see between the two, but it is a more addictive form of the drug. And typically, cocaine and other stimulants are used in a binge abstinence pattern. So they'll just use hit after hit after hit over a period of 12 to 72 hours. They'll just disappear into use, and then be abstinent for days before picking it up again. This is something to keep in mind when you're seeing people who are seeking treatment. They may say, well, I'm done with this. I haven't used in 2, 3 days, 4 days, 5 days. It's important to get a history of what their use pattern is like, because that may not indicate any kind of abstinence at all. That's just continued use because they're in this binge abstinence pattern continuously. So until they've done more like a week or two off of the drug, then they really haven't broken that cycle at all. Okay, so let's talk a little bit about some of the acute effects of stimulants. And these, I'm going to combine this with cocaine, amphetamine, methamphetamine. They all have basically the same medical consequences. So this is going to apply to all of those stimulants. So at low to moderate doses, you'll get the effects that people are seeking from these drugs typically. So you get euphoria, increased energy, increased libido, decreased appetite comes along with it, but also impulsivity, grandiosity, and increased alertness. So you get people feeling up, feeling good. At higher doses, you get more of the problematic side effects of these drugs. Insomnia is big, anxiety, irritability. You can get into confusion, paranoia, kind of psychotic symptoms with these drugs. And some other things from just the sympathomer. Reflexia, sweating, tachycardia, all of these types of effects, which some of which can be dangerous. And then an overdose, you get these very serious medical consequences, like seizures, strokes, heart attacks, and various kind of cardiopulmonary results of just putting a tremendous amount of strain on the cardiovascular system. And for pregnancy, it's important to note placental abruption can be a very serious consequence of this, because it's just cutting off the blood supply. Because I said it's a vasoconstrictor, so you cut off the blood supply to the fetus. That can be, obviously an emergency. So longer term, this is less recognized, but longer term consequences of stimulant use can be things like an increased startle response. So just on edge, and loud noises can set them off. This is long after even that they've stopped using the drug. These types of things can persist. Repetitive stereotyped behaviors you'll see, both when in intoxication, but it also can be a long-term effect. There's a phenomenon called punding, where they'll take, it's a very interesting behavior, but they'll take usually a mechanical device of some sort, like a radio or something like that, take it apart, fiddle with it, take the whole thing apart, put it back together again, take it apart again, put it back together again. That's a stereotype behavior. That's actually a consequence of the stimulant use. Some people do that with bicycles. That's actually a consequence of the stimulant use. You can certainly get cognitive impairment over time. It causes a clear decrease in frontal cortex volume and enlarged basal ganglia. So your kind of prefrontal control is being lost with these drugs over time, whereas your subcortical kind of urges are getting stronger, which that contributes to the addictive process. It makes people more impulsive, and you can get just more inappropriate behaviors just because of the way their brain has been impacted by this long-term stimulant use. And finally, you can get psychotic features, things like paranoia, delusions, hallucinations, that can go on for years after abstinence from the drug. So this would look like schizophrenia. It can, but even years after stopping, a lot of stimulant use, it could actually be a stimulant-induced psychotic disorder that eventually would clear up, but it can take a very long time. And it is quite common, actually, in long-term users. 25 to 50% of the estimates there. There's a particular type of hallucination, these tactile sensations called formication. It's a sensation of bugs crawling on you. That seems to be particularly common with stimulant use, although any kind of hallucination is possible with this. Okay, so we'll talk a little bit about withdrawal symptoms. So that's we've talked about kind of intoxication and long-term consequences. Another one is withdrawal. So when you withdraw from any substance, you'll get basically the opposite effect of what you got while intoxicated on a substance, just generally speaking. So with cocaine, what that looks like is hypersomnolence. They just want to sleep all the time. They want to eat everything, very strong cravings to use again, and depressed mood. So I just think of this patient that we used to see repeatedly who used a lot of cocaine and would come in, use so much cocaine, like all the organs would be shut down because they're so vasoconstricted. They would sleep for days in the hospital, and we would know they were waking up when all the food was stolen from the from the patients on the floor. They're so hungry when they finally wake up. And then the most profound depression I've ever seen, just like very suicidal and so depressed that they don't feel like they're even good enough to carry out a suicide plan. It's just, but it's all pharmacological. So that will clear up within a few days, maybe a week after use. You can also, but then you'll get into post-acute withdrawal, which can last for several weeks, where you get a lower level of depression, just lethargy and anhedonia, just not enjoying things. This can look a lot like depression, like a chronic depression. But again, if you, after several weeks of sobriety, a lot of these symptoms can clear up for people. So that it may not be that they have a separate depression. It may still be kind of a subacute withdrawal from stimulants. That doesn't mean you won't treat it. You can still give antidepressant therapy. It'll respond to that. But you may want to reassess the need for that after a more extended period of sobriety. Okay. So I've got some, we can talk a little bit about the medical consequences of stimulant use, some of which I've alluded to already, and you may be familiar with some of these, so I won't spend a ton of time on it. But cardiac events are a big one, because again, you're putting a huge amount of strain on the heart. So heart attacks, dysrhythmias, sudden death, overdose deaths are almost entirely these cardiovascular problems. And cardiomyopathy over time will develop with stimulant use. Related to that, you've got hypertension, hyperthermia. Again, that's the sympathomimetic effect. Aortic dissections, particularly painful and nasty possible consequence. And then pulmonary events, which are mostly secondary to the cardiac strain. Rhabdomyolysis, so just that the muscles are so activated that they actually start breaking down. That's a nasty consequence of stimulant use. And a lot of pregnancy complications, including, as I said, placental abruption, which is that really emergent problem. But you also get fetal growth restriction from stimulant use, because the blood supply is just reduced from having that stimulant on board for so long. So then the fetus ends up smaller because they just haven't been getting the nutrients. And I'll just mention here, there's no actual evidence for direct effects of stimulants on neurodevelopment. So people talk about this infamous crack baby stereotype, but there's actually no evidence that crack cocaine is going to cause some kind of problem in the fetus, other than this fetal growth restriction, as I said, which is secondary to the restriction in blood flow. And the mothers just tend not to take care of themselves. So they're not taking their prenatal vitamins, their nutrition is bad. So that's why you get a lot of these pregnancy complications with that. Yeah, and another one to mention is tooth decay. Meth mouth. This is much, you see this much more with methamphetamine actually, but you can see it with cocaine too. A lot of this is a result of xerostomia. So the mucous membranes, all the mucous membranes will dry up because of the sympathomimetic effects. So you're not producing saliva, which is actually very important for dental hygiene. And you combine that with the poor diet, poor hygiene, so not brushing their teeth, maybe drinking a lot of sugary drinks, you get rotten teeth with stimulant use. Okay, so now we could talk a little bit about treatments. So there's a lot of things that we know don't work for stimulant use disorder in terms of medications. Antipsychotics were a great idea. People keep trying that over and over again. But so far, it seems that antipsychotics just don't work with stimulant use disorder. Similarly, antidepressants have been studied over and over and over. They don't work. There is a thought that agonist therapy could work. We certainly, certainly seems to work with opioids and with nicotine use disorder, but it doesn't seem to work with stimulant use disorder in general. There may be eventually an agonist developed that is effective, but so far we don't have one. The exception to that is people with ADHD. So if you have attention deficit hyperactivity disorder, part of that disorder is impulsivity. And paradoxically, for reasons that nobody really understands, I don't think, people with ADHD, if they take a stimulant, their impulsivity decreases. And there's very good evidence that adequately treating ADHD with stimulants will reduce relapse rates, even if they have a stimulant use disorder. Adequately treating them with a stimulant can overall reduce their relapse rate. They tend to need higher doses, probably because they've developed some tolerance to stimulants, but the evidence is very clear on that. You can try non-stimulant treatments for ADHD, but guanfacine or Strattera, or atomoxetine. But the reality is they just don't work as well as the true stimulants. And so there's a lot of people whose ADHD really won't respond to anything but a stimulant. I'd say if you're gonna, so I encourage people to treat ADHD, even in people who have a substance use disorder, and actually especially in people who have a substance use disorder, but you have to be careful about how you're doing that. If the person has demonstrated that they will abuse these medications, you might want to find a family member or somebody else who can regulate their access to that drug to make sure that they're using it as prescribed. Because if they take it regularly at a prescribed dose, they're going to be much better off in a multitude of ways. So sometimes you have to get a little creative on how to keep them safe with these drugs, but it's a great intervention. And as I mentioned, we just don't have a lot of other options in terms of pharmacotherapy for stimulant use disorder. One thing that I'll prescribe sometimes is N-acetylcysteine. That drug has a kind of a general anti-craving effect. There's really good evidence for it in animal use. The human literature is kind of mixed as to how effective it is in the real world with stimulant use disorder. Sometimes I'll prescribe it again just because we don't have a lot of other options. And N-acetylcysteine is it's very benign drug. It has basically no side effects. It doesn't interact with things, and it may have other kind of health benefits, like it's an antioxidant and has maybe some mood stabilization properties. So it's something that you could try with people. It's actually not available over the counter anymore. You have to get it by prescription, but that can be useful. There's vaccines actually that have been developed for particularly for cocaine, but also other stimulants. Those worked better than I thought they would. but still the clinical evidence so far has been mixed at best with these. But I think the problem with the vaccines is that they haven't found ones that develop a really robust immune response in everybody. For the folks that we did produce a robust response in, they actually, I think it worked reasonably well for them. So maybe in the future you'll see vaccines that can be useful for cocaine and other stimulants, and those work by stimulating the immune system to the point where as soon as cocaine or something else is in the body, the immune system just chews it up, and before it even gets to the brain. So it just blocks those drugs from acting. Just takes that off the table as an option for abuse in people who get the vaccine. So there are other compounds. I figured I'd put these in here just to mention them. There's a number of these that have had kind of small trials, typically with mixed effects. Some trials showing a positive effect, some of them not confirming that. People will use these off-label sometimes, but again, that's more out of desperation than anything else. We just don't have a drug that works consistently to treat stimulant use disorder. So what does work is the behavioral therapies that we rely on for all kinds of substance use. So things like cognitive behavioral therapy, motivational interviewing, 12-step facilitation. These are the types of things that work for stimulant use disorder, just as they work for other forms of addiction. And in particular, the most effective is contingency management. So there's evidence for this with other drugs of abuse, but particularly in stimulants, contingency management is known to have very good effect sizes. So this is a type of therapy that uses tangible rewards to encourage behavior change. So the basic idea is that people will be tested regularly for stimulants and other drugs in their urine, and if they have negative tests, confirming abstinence, then they get some kind of reward for that, a tangible reward again. So a voucher, or just a monetary reward. Some of the best implementations are like a raffle, where there's kind of a gambling component to it. So the idea is kind of using that addictive tendency to promote abstinence rather than use. So very effective. It uses operant conditioning principles that we really know a lot about how these things should work. It's been studied for over 100 years, these operant conditioning principles, and the more recent human studies with contingency management they're just confirming things that were worked out by Ivan Pavlov, a century ago. So some of these are, seem kind of obvious, where using larger rewards works better with this kind of treatment. You're competing with cocaine, so a $5 voucher is not going to work as well as something with a couple $100. Frequent, immediate rewards work better than if there's a delay involved. And actually, that gambling scenario means that not rewarding every time, but giving them a chance to be rewarded actually gets better outcomes. Again, this is something that has been worked out through research over 100 years. One of the problems that people see with implementing contingency management is that it's often started with people who have very little training in it, very little support from whatever institution they're a part of, and so they don't follow the practices that are known to help contingency management be successful. So you get things like very small rewards, waiting for a long time before you give the rewards, and those types of things will really reduce the effectiveness of the intervention. There's also a lot of political barriers and related funding barriers to implementing contingency management. People tend to be uncomfortable with rewarding people for abstinence. I think this has to do with the stigma related to addiction. And so it can be hard to implement. Where you see this implemented very effectively is in the VA system, where you have a very hierarchical system there. It's not subject to a lot of the political forces that you see outside. They can just use evidence-based practices. And it was implemented there with a lot of institutional support. So people were well trained, and there was support all the way up the chain of command. And they see good results with that in the VA system. Very recently, just a few weeks ago, California approved Medicaid reimbursement for contingency management. That's a big barrier for a lot of places implementing this. It's actually the state can choose to interpret some of the limitations on Medicaid reimbursement to say that we can't reimburse for contingency management because you're giving a direct payment to the patients. They don't have to interpret it that way. And so California has just recently decided not to. So hopefully we'll see more contingency management there. All right, so maybe I'll go kind of briefly through amphetamine, methamphetamine. So amphetamine, methamphetamine are derived from Ephedra, the Ephedra plant. This is a little kind of scrubby grass looking plant that grows in desert areas in several areas in the world. It contains both ephedrine and pseudoephedrine in the plant. Again, it's been used for thousands of years. The Chinese call that mahuang. And in North America, it's known as Indian tea or Mormon tea, which I thought was interesting given the Mormons' reticence with psychoactive drugs. But the active ingredient here, ephedrine, was isolated again in the late 1800s and quickly developed into amphetamine and methamphetamine, which you can see if I toggle for that's very easily derived from those precursors. So the way these drugs work is they will inhibit monoamine reuptake. So that'll be dopamine as well as serotonin and norepinephrine. The dopamine being the addictive part of that process. So you get more dopamine in the synapse here. It also causes internalization of the dopamine transporter. So you get less transporter available. It inhibits packaging of dopamine and other monoamines into the vesicle, so there's less of it to release by the vesicle, and instead it takes all of this, so it dumps all of this stuff out into the cytoplasm, replaces it in these vesicles, and then it will reverse the transport in whatever dopamine transporters are left, so that those end up pumping out all the dopamine from those neurons into the synapse. So it really takes every possible way to squeeze every last drop of dopamine out into the synapse. So these are very powerful dopaminergic drugs. I don't think we really have time to go through much of the history. I'll just skip over a lot of this history of amphetamines. Interesting, but we'll skip over this. But I will, I'll give you, so just to taste of this. So methamphetamine, this is the big one. That's amphetamine is less popular now. It was more popular in the post-war era. But methamphetamine was produced in the West, in San Francisco, and it was controlled by biker gangs out there. And then production kind of shifted towards Mexico in the 70s. So the current kind of methamphetamine wave started out West with these already established gangs and the production sites in Mexico, and then moved eastward. So today, where you see methamphetamine, it's a little hard to actually track this in a lot of detail. So these data are based on meth labs that were busted by authorities. So it's mapped out by county. And so you see that there's still a lot of methamphetamine on the West Coast here. But this activity has really become concentrated in the Midwest. And Michigan has some areas that are pretty hard hit by methamphetamine, particularly in the western part of the state. It tends to be in rural areas where you get big methamphetamine problems. If you notice in the really population dense areas of these states, that's not where you're seeing the methamphetamine production. And that's in part because of the way that methamphetamine is produced. So a lot of this is actually produced locally, where people are making methamphetamine and distributing it themselves. But the process of making methamphetamine is messy. At least, especially if you're making large quantities of it. There's ways to make it less messy if you're just making a little bit of it, but you need a lot of harsh chemicals. There's smells that go along with that. There's things can light on fire and explode very easily. And these are not they're not typically organic chemists who are doing this. They don't have sophisticated equipment. This is what a typical meth lab is going to look like. It's just some schmo who's on methamphetamine and is making this. So it's not going to be safe conditions. You're going to get emissions all over the place, and so it's just easier to get away with this in a rural setting where you're away from other people. Then, like, if this is in the apartment next door, it's not going to take long for people to notice that something's going on. Okay, we don't have much time left, but I'll leave a little time for questions. But I do want to mention there are other drugs related to amphetamine. There's a whole laundry list of drugs that you can derive from amphetamine. And a lot of them have addictive potential. This is where there's a long and growing list of designer drugs and club drugs that have been designed from amphetamine. And these will become popular. It goes in fads, partly because these are all legal when they're first made. You have to, the way these drugs are scheduled, it's by the chemical compound. So you can't just say anything derived from amphetamine is illegal. You have to specify what is illegal. So all you have to do is change the methyl group on here, and now it's a legal drug. So sometimes we get some creative people who just make something new themselves and start using that. But just keep in mind, there's a wide variety of potentially addictive stimulant drugs. Okay, I think I'll stop there and just give a couple minutes in case people have questions they want to ask. But
so if anyone has any questions, feel free to. Oh.
Let me just.
Was there a question? I wasn't sure if that was someone asking a question or something else. I don't see any in the chat either. So real quick, the code for the CEUs or the code for the CMEs and then the link for the survey for the CEUs are both in the chat if anyone needs those. And also a behavioral health consultant will be reaching out to everyone who attended today. So if you have any questions about anything, feel free to let them know. And a recording of the webinar will also be posted on our website, which is Michigan Opioid Collaborative.org within the next week or so. So if there are any questions, feel free. Thank you, Dr. Morrow, for the presentation.
All right, thanks. And thanks everyone for coming, for attending.